Thank you for joining my presentation on RSV in adults. My name is Terrence Shenfield and I've been an education coordinator for most of my career. RSV is typically thought to occur in children, but let me tell you, it can occur in adults. But the difference is, in adults, it could be life-threatening. So at the end of this presentation, you're going to know everything you need to know about RSV in adults. Today's objectives are, I'm going to describe what is RSV, why it's important to reduce the spread of this infection. I'm going to get a little bit onto the epidemiology, the etiology, the pathophysiology. I'm going to talk about the clinical manifestations of RSV, some treatment options, and methods to reduce the spread of it. By the end of this presentation, you're going to have a good background on exactly what is RSV. So what exactly is RSV? RSV was first identified over 50 years ago. And basically what they were looking at is the epidemics that occurred in the 1930s and 1940s. And what they showed was during each winter season, there were certain illnesses being occurred in children as well as adults. But they really didn't know exactly what was the disease, what was the origin of the disease itself. So then in 1955 at the Walter Reed Institute, where they did a lot of research, they actually isolated the virus from the nasal secretions of young chimpanzees. And at this point, they called it chimpanzee coryza agent, or CCA. Then in 1956, Robert Chanock isolated the virus from two infants with the characteristic multinucleated giant cells, and basically they renamed it RSV. So I have a nice image of exactly what I mean by multinucleated giant cells, but it's very obvious when you put this under a microscope exactly what kind of virus this is. So this is a little bit more background on the virus. It is what is known in the paramyxovirus family. Typically, the paramyxovirus family is either the mumps, measles, as well as the parainfluenza virus. So it's in the same virus family. It is known as what is called an enveloped virus. What that means is that it has a bilipid membrane around its outer core. How this works is because of this bilipid membrane that is around the virus, is actually protected from degrading. So in other words, this virus can stay on surfaces in cold water and last for a long time. That is why it's most prevalent during the winter months. So this virus is particularly a very hardy virus, and that's due to the bilipid membrane, and it could stay on surfaces for a long period of time. And what happens is in the summer, that bilipid membrane melts and then the virus dissipates. So this is a little background information on this particular virus. One of the distinguishing features of the RSV virus, when you look at under a microscope, is a term what they call polynucleated viruses. This is where all the viruses all bundle up together in nucleuses of cells, and it gives this characteristic look under the microscope. You can see all these clusters of cells, and this is quite distinguishable with RSV infections. So this is how you could recognize it under the microscope. So let's talk a little bit about the RSV prevalence in adults. As we know, children and infants are the ones who most likely get RSV infections. As a matter of fact, over 85% of us always had an RSV infections in the past. So you, me, and 85% of us who are listening to this have had RSV. But because our immune system is strong, it kicks its butt. Now, when I say kicks its butt, I don't mean eradicated the RSV virus. So basically, our immune system, if it's intact, it will fight off the virus and we'll get better. And then we can get recurrent RSV infections throughout life. Every year, about 125,000 children are admitted to hospitals due to RSV infections. And over 4 to 5 million of them stay home. So a lot of kids get RSV infections, they get better. But the RSV infection that our bodies fight back and get better with stays with us. It doesn't go away. As a result, as we get older, we sometimes get recurrent RSV infections as an adult. And sometimes these RSV infections are masked by the fact that we think we have the flu. But every year they approximate there's about 14,000 deaths each year in adults from RSV. Now, the difference between an RSV infection with a child versus an adult is typically an RSV infection with a child will be the upper airway, like the nasal passages. But with an adult, it worked its way down to the lower respiratory tract. So a lot of times adults who have RSV infections come in with bronchiolitis, and they also come in with cases of pneumonia. And as I was saying to you before, RSV infections, our immune systems are really good, but it does not eradicate the virus in our body. There's no type of drug that will kill the RSV virus, and the fact is that our immune system stays strong, we can control the outbreak. But as we get older, as adults become immunocompromised, as we become elderly, as we maybe, God forbid, some patients get HIV positive, or if they're on chemotherapy and their immune system is weakened, or if they're a transplant case, they can be really severely ill with RSV infections to a point of death. So it is around with adults, and this is a little bit about the prevalence of it. Let's talk a little bit about the transmission of RSV. RSV is transmitted between patients by either coughing or sneezing, and the secretions and droplets are released from the patient who has the virus. These secretions can be on bed sheets, they could be on pillows, and they could dry, but they actually stay very viral that they can be transmitted to another patient. Typically, they could stay on environmental surfaces for anywhere from 4 to 7 hours. Also, studies have shown that they could be on your hands for greater than 30 minutes. The typical incubation period for RSV is anywhere from 2 to 8 days, and this is for your first time getting RSV infection as a child. There's a term called viral shedding, which I'm going to get a lot more into, but typically viral shedding is when the virus is multiplied in your body and then is shed through the process of coughing or sneezing, and this actually releases it from the patient, hoping to find another host. But typically viral shedding averages anywhere from 1 to 12 days, but most typically it averages anywhere from 4 to 6 days. If you happen to be immunocompromised, or if you happen to be a very young child, viral shedding can be extended up to 3 to 4 weeks. So that means that that patient is very contagious 3 to 4 weeks, and they are very contagious anywhere from 1 to 12 days. But typically, most of the time, it's about, typically the evidence shows about 5.6 days. So it's anywhere from 4 to 6 days. So this is a little bit about that epidemiology of RSV. So how do you diagnose an RSV infection? To start off with, most RSV infections occur when you're an infant or a young child. And the most common method to do is what is known as an antigen detection immunoassay test, which typically takes about 1 hour. The problem with this test is that it's highly sensitive in children, so it works well in children, but it does not work very well in adults. And since this lecture is about adult RSV, if you suspect the patient has an RSV infection who is an adult, this test may not be the most sensitive. If you really want to do a good test, you should do what is known as an RRT-PCR test, which is really highly sensitive, and it really is a great test. It's like 100% accurate. The problem with this test, it costs a lot of money. But if you're an adult and if you're immunocompromised and they suspect that you might have an RSV infection, this might be your only choice. So the typical process is to put a nasal swab into the nasal cavity, and you swab out a result, just very similar to the way they swab out with COVID. Another way of doing it is use an endotracheal tube aspiration. And that really sort of could work well too, especially if you send it to the lab and you get what is known as the RRT-PCR test. You could also send it to the lab and do what they call viral cultures, but the problem with these viral cultures is it takes 3 to 5 days. So these are the most common diagnostic testing that you would do for this particular virus. So when did RSV infections become noticed? When did we start paying attention that RSV infections were occurring in adults? It really didn't take place until the 1970s when they were realizing there were a bunch of outbreaks in long-term care facilities, especially in the New York area. At this point, they really didn't know if a patient had an influenza virus or if had an RSV virus infection. And they decided to do some tests with those patients, and they came up with some kind of stats of how many patients in the community, how many patients in a nursing home, how many patients who are just healthy elderly patients, how many of us have been colonized and symptomatic with RSV infections each year. And remember, the RSV infection occurs right around the same time you get the flu. So you really don't know. And a lot of the symptoms between an RSV infection and a flu infection are similar. There are some differences, and I'm going to get into that a little bit later. But at this point, they believe that community-acquired pneumonias were occurring due to RSV infections due in the rate of 2 to 5%. So when you talk about community-acquired pneumonias, and they came into the hospital and then they did some antigen testing and they did some PCR testing, 2 to 5% of them actually had an RSV infection that led into the pneumonia. Then we talk about nursing home rates. Nursing home rates showed that there was a breakout of RSV infections in the range of 5 to 10% annually. And this occurred exactly at the same time when you get the flu. And then when you talk about healthy elderly patients, who are healthy elderly patients? These are your neighbors. This is your uncles. These are the people you know in the community. They're healthy. They go about their life. You know, we all get the flu here and there. We all get colds here and there. But of this normal population in our community, they get RSV infections in the rate of 3 to 7%. And like I said, the symptoms for an RSV infection and flu are very similar, but there are differences. And I'll get a little bit more into that later. As I was saying, back in the 1970s, they began to realize that adults are getting RSV infections, and then they looked further into high-risk adults. When I say high-risk adults, I'm talking about your patients who are COPDers, or they could have other pulmonary disorders like asthma or emphysema or a host of other type of pulmonary disorders, heart disease. And in this particular population, they have a range of 4 to 10% of RSV infections. And let me tell you, when you have COPD or if you have heart disease and you get an RSV infection as an adult and it could lead into pneumonia, it could really actually impact you a lot more. How many of these RSV infections were related to hospitalizations? They did some studies again where patients who were admitted for pneumonia, 10% of them was a result of an RSV infection. And how about your exasperation of COPD? As you get these COPDs that come back into the emergency room, how many of them actually have an underlying RSV infection? And they put that number around 11.4%. So you get your pneumonia cases who require hospitalization, you get your exasperation of COPD, and both of these numbers are pretty significant. They did a study by Thompson and his group, and they looked at the number of cases of RSV infections that resulted in fatalities, and there was approximately 10,000 deaths each year for patients who are over 65 years of age. So this is alarming. Here you got these RSV infections occurring in the hospital, you get these people in the community getting RSV infections, and we don't really got a good handle on it. So these are some of the stats that you should know about. So this is very alarming. they did a study looking at nursing homes in the New York area in Rochester, and the patients were assessed either if they had influenza or an RSV infection. And what they found in these particular sites was 3% of the RSV cases were from one facility and 20% of the RSV infections came from another facility. So their numbers were alarming. When you think about long-term care facilities for the elderly, and you think about this cluster of patients who are getting infections with RSV, let's think about COVID. How many of these New York facilities, long-term care facilities, had high mortality rates? So at this particular study, they recognized there's approximately 14,000 to 62,000 RSV hospitalizations annually from long-term care facilities. So people are getting sick in these facilities, and they're actually being brought into the hospital. Over time, now this study was done in the 1970s, but it really hasn't been, RSV vaccines have not really been that promising. And what has been promising is the influenza vaccine. So over the years, what you're doing is you're getting less influenza cases due to the fact that patients are getting vaccines, or those residents are getting vaccines, yet no one is getting a vaccine for RSV. So what this means is you have an increased hospitalization rates based on RSV rather than influenza. And this is alarming. If they are doing some research on vaccines, there's a couple of vaccines out there, but they're not completely effective. And another problem, remember, when you get the RSV infection as a child, you build up a certain immunity, but you do not eradicate the virus from your body. So that means if you get another RSV infection, yeah, you built up some form of immunity that could fight it, but you're not going to rid of it completely. So we're going to get more into immunity and talking about how you can fight off infections a little bit later. But this kind of data is alarming, and you got to remember now most of the patients, most of the residents in these long-term care facilities do get the influenza vaccine, so there's less cases. But what we're going to see on the other side of that is an increase of hospitalizations from RSV infections because there's not a vaccine on board for that. Let's talk about some risk factors for RSV patients. There's a few things you should understand. First of all, if a patient has a chronic medical condition, that means that their risk factors go up on the severity of RSV infections. And basically, there are two types of infections. There's a type A and a type B. Basically, it's both RSV, but the type B infection is more severe and can cause hospitalization. When you think about risk factors, some of the risk factors involved are senior daycare programs, and you're saying, why are senior daycare programs risky? And the reason is most of these senior daycare programs, at least in the pre-COVID era, would have visitors at their center. A lot of young children would come to the daycare centers and say hello to the adults, and the adults would say, oh, how sweet, beautiful little child. Meanwhile, those little child have colds or they have RSV infections, and they can transmit that to the senior citizens. And as a result, they could get an RSV infection or get reinfected. A lot of times the support staff, how many people can call in sick when they got the sniffles? Not many these days. They got an enforcement of policy controls for attendance. So some people come to work and they got RSV infections and they just work through it. But the problem is they could actually transmit the virus to the people at the center. So these are some of the risk factors, and the biggest one you got to watch out for is whether the infection for the year is type A or type B. And typically you don't get the same season with the same type. So one season might be B, the next season could be B, the third season could be A, and so on and so on. So these are some of the risk factors involved with RSV infections. Another important consideration is RSV infections in long-term care facilities. In today's day and age, it seems like many people end up going to a nursing home or a long-term care facility. And every season, every flu season, people get sick. But over the years, they've had a steady increase of the use of influenza vaccines at these centers. So the influenza vaccine is doing its job and people are not getting the flu. But what's on a rise is RSV infections because there's no really standardized way of preventing an RSV infection because the vaccines are less than desirable. They're not really perfect yet. I'm going to get a little bit more into the vaccines as we go along, but the truth is they really are not dependable. So as a result, RSV infections are in the neighborhood of 5 to 10% in nursing homes, and this normally occurs during the influenza season. And the problem with this is that a lot of these patients who have underlying medical conditions and chronic conditions end up getting pneumonia. And if typically around 10 to 20% of the group who happen to have an RSV infection now will have a pneumonia and then result in hospitalization. And also, if you look at death, the death rates from an RSV infection are somewhere in the neighborhood of 2 to 5%. So in the long-term care facilities, you really got to watch, and obviously we've seen what happened with the COVID pandemic, especially in the state of New York where there's a lot of deaths there. So RSV, they're working on some new vaccines, but currently the vaccines are okay, but not that okay. So let's talk about the community dwelling elderly. And who is the community dwelling elderly? Those are the people who live next door to you. That's your aunt, that's your uncle. It may even be, well, you. But basically, when you are typically healthy and you're retired and you're living your life and you're living the dreams of retirement, a lot of times these patients in the community get what is known as community-acquired pneumonia. And there's approximately about 14% of the elderly population get this. Now, the cause of a community-acquired pneumonia could vary. It could be bacterial, it could be viral, it could even also be fungal in nature. But in regard to RSV, they are saying that many patients who get community-acquired pneumonia is resultant of an RSV infection. The problem is normally an RSV infection typically occurs right when the flu season. So you really don't know if it's the flu or if you don't know if it's an RSV infection. But the problem with it, if it is an RSV infection, it can work its way down to the lower lung fields, end up giving you a pneumonia. So that is part of the problem in the community. And like I said, they're working on vaccines, and I got a whole few slides to go into it. But community-acquired pneumonia is a problem with the elderly in our neighborhood, and this is not in a long-term care facility or LTAC or any place like that. This is Joe next door. So you got to be aware of this. Let's talk about the combination if you happen to be a COPDer and you get an RSV infection. When you are a COPDer and you are predisposed to an RSV infection, your risk goes through the roof. They did some studies, and there's not many studies, so a lot of people who have an exacerbation of COPD, not every one of them was tested for the antigen test to see if they were positive for RSV. But they did some small studies, and I think they should do more studies. With the small studies they've done, they have found that almost 18% of the patients with the COPD exacerbation exhibited elevated antigen levels of RSV. They also found in 17% of chronic bronchitis cases, again, had elevated antigen levels for the RSV infection. Like I said, they don't really typically swab you to see if you're an RSV infection with a COPD exacerbation, but they did do some small studies, and probably in the future they're going to do a little bit more. They did a study in Scotland of 96 subjects displaying RSV antibodies, and 85% of them turned out to be positive, and over 50% of them showed to have chronic bronchitis. So there's absolutely a link between RSV infection and being predisposed for COPD exacerbations. So what's the role of RSV infection in cardiac disease? What they have found, I guess, again, there's not much information out there except for that Rochester study in New York where they looked at the long-term care facility. They found that 63% of those hospitals with RSV infections also had an underlying cardiac issue. So, and congestive heart failure is the most common cardiac issue that they found an increase in RSV infection with. So the bottom line is this: if you happen to be a cardiac patient with underlying cardiac disease and you happen to get an RSV infection, your rate of hospitalization will increase. Also, besides hospitalization, you have an increase in morbidity and mortality for any other kind of cardiac event going on. So there is a relationship. How powerful the relationship is, they need to do more studies on, but they definitely found some form of relationship there. So just food for thought. Any of you who happen to have asthma will relate to this. Myself, I have a little bit of asthma, which is typically very well controlled. I don't really have many severe exacerbations, but there are times when I get a cold, and I'm sure everyone can relate to this who has asthma. When you have a cold, your asthma severity increases. And the question is, let's talk about predisposing factors to an asthma attack, and an RSV infection is one of them. They have shown that the rates of documented RSV infections in adults with asthma has risen in the recent years. And another thing that's very important to consider, when you have childhood RSV infections, and if they are severe, this could be a risk factor for asthma later in life. They were looking at the economic burden of RSV in adults, and they estimated to be approximately $150 to $160 million annually, and that's just for pneumonia. But if you count in exacerbations of asthma, exacerbations of COPD as a result of an RSV infection, it's really kind of costly. So this is something really strongly to be considered. Beasley and colleagues, they did a survey. They looked at 178 asthma exacerbations in the emergency room, and they swabbed them. They tested all of them. And of those 178 asthma exacerbations, 10% of them actually were positive for RSV upon admission. And one of the most common signs of RSV infection, even if you're not an asthmatic, is severe wheezing. And what happens is, if you never wheezed in your life, you don't have asthma, and you happen to have an RSV infection, one of the telltale signs is you're wheezing. So you think you got a cold and now you're wheezing. There's a good chance that's an RSV infection rather than influenza. But of these cases, 89% of them was associated with wheezing, and almost 38% of them were judged to be severe. So if you happen to get an RSV infection and you happen to be an asthmatic, you can anticipate that your regimen and treatment plan for your asthma management is going to be increased. So these are some considerations. What about RSV with cancer patients? Most cancer patients, and I'm also going to include immunosuppressed patients who might be HIV positive or some other kind of condition which suppresses their immune system. The problem with RSV infections and these patients is that the rates of pneumonia can go up to 80%. What happens is there's not many treatment options, so you're immunosuppressed and you get an RSV infection and then you go into pneumonia. The mortality is actually through the roof, very high mortality. Actually, the only particular medication they use as a treatment option is ribavirin. They aerosolize ribavirin, and we all remember that. The problem also with this particular group is the shedding time. Normally, like I said before, we shed anywhere from 4 to 6 days, and this is a graph of a child's shedding pattern on the right. I'm going to get more into shedding, but whatever the case is, if you are immunocompromised for whatever reason, be it cancer, be it that you have HIV, your shedding period is much, much longer, and as a result, this is when you could make someone else sick. This is when you are the most contagious. So patients who shed for a long time are very, very contagious, meaning they increase the risk for those who are around them, namely you and I. Nosocomial infections and RSV. This is a real problem for adults. What happens is the mean time after admission to the diagnosis of an RSV infection is 11.5 days. So what that means is patients are admitted into the hospital and they may have an underlying asthma attack, or they might have a COPD exasperation, or they might have some other cases. But the problem is they're not diagnosed for RSV infections. And during this time, they can spread the virus because of viral shedding. RSV infections have also been documented in many ICUs, but especially the oncology units and the bone marrow transplant units. Any patient who's immunosuppressed and happens to have an RSV infection is predisposed to getting a pneumonia. If they get a pneumonia, the mortality rate is like 60%. So when many of these patients who are underdiagnosed or not diagnosed at all, and the mean time to diagnosis is 11.5 days, they are shedding. They are shedding the RSV virus. What that means is healthcare workers, us who is taking care of them, can get the virus and transmit it to other patients and coworkers. So really good hand washing techniques and PPE equipment is very important at this time. They also did a study looking at intubated patients during flu season. Typically flu season, which is sort of mirrors RSV season, is from January to March, and they found that many patients who were intubated during this time also had an underlying RSV infection. And again, this could be spread to healthcare workers. So this is a real problem, and it's under-recognized, but I'm just pointing this out to you so you might have this on the back of your mind next time you take care of a patient during these seasons, most likely between November and April. Let's talk a little bit about viral shedding. What viral shedding is, once the virus enters the body and reproduces, it will stay in a person as long as there's plenty of resources to reproduce. After a while, when the virus feels it's exhausted all the resources in some person's body, it wants to replicate and it wants to survive. So what it does, it reproduces itself and then sheds from the host body in the form of a cough or a sneeze. Hopefully that it will attach to another host and then start the whole process all over. So viral shedding is the process where the bacteria utilizes all the resources in the host, and then once that's done, and this is the time when they're very contagious too, and once that's done, they actually expel from the host body with the hope of reinfecting another host and starting the whole process all over. So you could say this is the time when they're extremely contagious. Normal shedding for the RSV virus, like I said before, is anywhere from 1 to 12 days, but most of it is done between 4 and 6 days. And unless you happen to be a immunosuppressed person, where the shedding could really be quite long. Typically, 85% of us have had an RSV infection at one point in our life. And maybe we had multiple bouts with RSV infections throughout our life. The thing is, most of the time, RSV infections don't kill us. They actually appear to be like a bad flu or something like that. But basically, by the first 2 years of life, you had your first infection and you built up your first immune response. The problem with RSV, even though we build up an immune response, our immune system doesn't eradicate the virus. It doesn't build up such an immunity that if we get an RSV infection, that we are asymptomatic. The key is you build up a partial immunity. And this partial immunity will fight off the virus. Your shedding days will be less, but you will still be symptomatic. So even if you have another recurrent RSV infection 2 years later, again, you could be symptomatic. And again, your shedding period of time might be less, but your immune system doesn't eradicate the virus. Now, when you look at the severity of viral shedding and you look at viral load, there's a way of doing a PCR to determine your viral load. And other examples of RSV shedding cases are with the immunocompromised patient. In the immunocompromised patient, because their immune system is impaired, they do not eradicate the virus. They do not clear the virus. They actually shed for a much longer period of time, and they become more contagious, and they can infect other people. Other viruses that shed are like hepatitis C and HIV. So viral shedding in viruses is a normal process, and this is how the virus will survive. You know, once it exhausts all its resources with a host, it's looking to go somewhere else. So understanding that we have a partial immunity, we don't eradicate the virus, is very important, because as we get older and as our immune system weakens, that RSV infection become more lethal. When you're a child, the typical symptoms of an RSV infection is an upper airway, like your nose gets congested and something like that. But as you get older, that virus is a little bit more severe, especially if you're immunocompromised. It works its way down to a lower lung infection, typically a pneumonia. And if you get a pneumonia and you're immunocompromised, your mortality goes up through the roof. A little bit more on viral shedding. I wanted to show you the duration of shedding for different populations. So, for example, if you're a child and you actually get your first RSV infection, the typical shedding is about 9 days. So you could be shedding because you don't have any kind of immune response. So you first get the virus, and all of a sudden you start building up an immune response, and that typically lasts for 9 days. Then when you're a child in the ages of 2 to 16, you shed from 3 to 8 days, shorter. Why do you shed shorter? Because you built up a partial immunity. Adults, they shed anywhere from 3 to 6 days. Why? Because again, they have a sort of a built-up immunity. Here's where we get into the problem. If you're immunocompromised, because your immune system can't fight off the virus, you're going to shed up to 30 days. Shedding doesn't matter by your gender, male, female. Things that could lead to increased shedding or risk factors are age, the severity of your illness, and the shedding patterns related to previous illnesses. So if in the past you typically shedded very shortly, you could almost anticipate that you're going to shed the same way with future illnesses. And the flip side to that is if you took a long time shedding and you were contagious for a while, most likely you're going to continue in that same pattern. So this is a little bit about the viral shedding patterns and the amount of time it takes. So when I was putting this presentation together, I was starting to wonder to myself, why do RSV infections and influenzas occur seasonally? In other words, why every winter do we get a flu season? Why do we get an RSV season? Why in the summer is RSV season not here? And the answer is they really don't know, but they got some theories. Here's one of the theories. During the winter months, when we're put it this way. Let me flip this. In the summertime, we're outside, we're in the parks, we're riding our bicycles, we're jogging. We are not in close proximity with each other. We could be sitting at a picnic bench, whatever we are. But in the winter months, because it's cold, we all huddle in the same area. In other words, you know, when you take a break for your lunch or breakfast, you typically all huddled at a table and you're in close proximity. And this goes for schools, this goes for homes, this goes for work. So what happens is that close proximity makes you actually share a virus. So if one of the people at the table is sick, it's very easy for them to share it with you. Another concern is in the winter, the mucous membranes in our nose is sort of dry because of the cold weather. And this dryness of mucous membranes actually can lead to a poor defense mechanism. In other words, you know, your defenses are best when your mucous membranes are moist because they could catch particles and you could expel them out by sneezing. But in the winter, your mucous membranes are drier, and as a result, they could work their way right into your airway. Another thing is, remember I was telling you about the enveloped shell around the virus? It has this bilipid membrane. So what that means, in cold weather, that bilipid membrane stays intact. Think of a frozen wax or cold wax. It doesn't melt, so it could stay on surfaces longer, and that means you could get that virus, you know, by touching some kind of surface. They also were looking at vitamin D production from ultraviolet B, and what they found that people who don't get enough sunlight have an impact in their immune system. So, and finally, the National Institute of Child Health and Human Development, they felt that the influenza virus, like the RSV virus, has this coating, which I just mentioned to you. And in the winter, that coating becomes like hardened. It's like a shell, and it can survive in cold weather. But in the summer, when warmer weather comes, that shell can dissipate and melt, and this is why you have less cases. So this is some of the reasons why they believe that RSV and influenza is seasonal rather than just year-round. This is a chart showing the RSV infection peak months versus the influenza peak months. And if you look at it, let's start off with the influenza. Typical influenza occurs anywhere from October to April, with the peak occurring anywhere from January to March. So influenza season is from October to April, with peak times anywhere from January to March, winter time. Now, if you look at the RSV infection, they typically are anywhere from November to May, right? So they occur anywhere from November to May, which almost mirrors the time for influenza. So if you get an RSV infection, you may think you just have the flu, and you don't really realize the difference. But there are differences in symptoms. Certain things occur with RSV infection that don't happen with influenza, and the opposite is true. Certain things happen with influenza that don't happen with RSV. So I just wanted you to realize, like, over the years, many years of study have shown that the season for RSV and influenza are superimposed on each other. So this is a great chart. This is going to show you the symptoms of RSV infection versus influenza A. And they are different. And some of the key things you got to pay attention to is these factors. For example, with RSV infection, you typically get a lot more nasal congestion. You know, almost like they looked at the cases of 68 versus 55. So RSV infections, more nasal congestion. Another key point, RSV infection typically will result in more wheezing. So you typically don't wheeze. Like, you may not have asthma at all, and you may start wheezing because you got a cold. And if you do have a cold, you think you have a cold, and you start wheezing, most likely it's going to be an RSV infection. So that's one of the differences. And another difference, Like I said, wheezing right down here, you can see that it's a real component of that. And you notice the duration of symptoms is a little bit longer with RSV versus influenza. And typically you do not get a fever with RSV infection, but you get a fever with influenza. So, and also you're predisposed to pneumonia with RSV versus influenza. So some of the key points you need to know: if you have nasal congestion, if you have wheezing, if you have no temperature, and you are just sicker longer, it may be an RSV infection rather than an influenza infection. But they're kind of close, but these are the key differences, and I was alluding to this a little bit earlier. So I was going to go a little bit into the clinical manifestations of RSV infections. First, I'm going to start with young adults. Because this lecture is mostly about adults, I'm going to break it down into adult world. Typically, as a young adult, your RSV infection will be limited to your upper respiratory tract, meaning your nasal congestion, you get a mild fever, you may get a non-productive cough, you're definitely going to get some kind of wheezing, and you might have a persistent fatigue for about 4 weeks post-illness. So the duration of illness with RSV infection is pretty long. You get beat up. You get your wheezing, you get your nasal congestion, but most of it is in the upper respiratory tract. So this is a slide speaking about the clinical manifestations of RSV infections in elderly adults. And typically, the difference between a young adult and an older adult is that instead of getting an upper airway infection, you get a lower airway infection. And a lot of times you get more severe nasal congestion. You also get a cough, which is very common. And again, you won't have a fever as compared to influenza. You definitely may get some wheezing and rales based upon auscultation of the lungs. And the sad part of this is that 10% of you will develop a pneumonia. So the difference between the young adult and the older adult, the young adult has upper airway infection, where the elderly adult has more lower airway infection, which could actually lead into pneumonia. So it's a little bit different and more severe. So I wanted to highlight some of the principal methods of diagnosing RSV infections. And the 4 most common methods are cell culture, antigen detection, serology, and RT-PCR. Let me just say one thing. With a cell culture, basically you get some nasopharyngeal aspirates, you get some nasal washes, and then you actually culture the cells. But it takes 4 to 5 days to see the results of that, which is, like, to me, way too long. Your other choice is antigen detection. Again, this can be done through nasal washing. The problem, there's a benefit and there's a problem. The benefit is it's very fast and it's very sensitive in infants and children. So in other words, the test results very well with infants and children, but it doesn't work that well in adults. So it's fast, but it's useless. Another test of doing is serology, which basically you get a blood test and you're looking at antibodies rising. And again, this takes too long and it's just another method. The most accurate method is the PCR. And the problem with the PCR, it's very sensitive. In other words, it's very accurate, very sensitive. It works both good for the adults as well as the infant. So this is the best test. The problem why they don't do it, it's expensive. Nobody wants to spend a lot of money. When was the last time did you go to the doctor and they did a PCR while you came in for the influenza, or you came in because you had a bad cold? They don't do it. And the reason they don't do it is because they're trying to save money. But it is the most accurate test, and it can be very useful in certain populations, especially when you get elderly and especially those who are immunosuppressed. So what is the treatment for RSV infections? To this date, there is no drug that can kill the RSV infection. It just doesn't exist. So most of the care for any population is supportive. Basically, you might get a bronchodilator, you might get some fever-reducing medication, you might get some supplemental oxygen if you're severe. Um, They have some drugs that work kind of well with infants and children, polyvizumab, which is a medication that actually decreases the severity of the RSV infection but does not eradicate it. In the elderly patient, it's more supportive. Again, there's no drug that you could use, and the polyvizumab doesn't work as well with the elderly patient. Now, in regard to the immunocompromised, I said that is your worst case, your chemotherapy, your HIV patient, or other reasons why the patient is immunocompromised. They decided to use ribavirin. It's effective. It actually decreases the viral load. It actually decreases the morbidity and mortality of anyone who happens to have an RSV infection. Again, ribavirin, I've actually never used it as a respiratory therapist. When I came into the field in 1992, there were a bunch of SPAG, I guess they were called SPAG scavengers, where they would actually get rid of all the bad humidification from the ribavirin treatment. But they still use it. They use that for the immunocompromised patient. But like I said, there's not much you can do. It's mostly supportive. Probably the best thing you could do is vaccinations. So as we know, there's no actually drug treatment for RSV infections. So what's the best way to do it? Might be prevention and vaccination. It seems like humans are the only ones who are known reservoirs for the RSV infection. So in other words, we can keep this infection in our body and our immune system is strong enough to suppress it. We are asymptomatic. We have no problems. Back in the 1960s, they actually created this vaccine called formalin inactivated RSV vaccine, and they gave it to a bunch of kids. The result was it increased the RSV symptoms, so it really was a bad choice. And as I mentioned, RSV infections have two types, type A and type B, and they hopscotch. I mean, it's not like a perfect thing. A one year, B another year, A, B, A, B. It could be A, B, B. It could be A, B, B, A. It could be whatever. But typically, the type B infection is more severe. As mentioned earlier, we have a natural immune system to fight off RSV infections. And it does a pretty good job, but it's a partial immunity. In other words, we built up some kind of immune response, an adaptive immune response. Our T cells have some kind of an adaptive immunity, but we can't kill the virus. So we keep on getting recurrent infections. So they looked at different types of vaccinations for it, and they have one called a neutralizing immune globulin or humanized monoclonal antibodies, and they have been shown to be kind of positive for infants. And then we have these other vaccines called non-replicative vaccines, and they may be useful with the elderly population and high-risk children. So you have two classes of immunizations or vaccinations, and each one has its own merits. One's better for children, one is better for adults. The most current research we're doing on vaccination is broken down into three types. They all considered subunit RSV vaccines. That means that they're inactivated vaccines. And the three types is one is known as a purified F protein, the other one is co-purified FG and M proteins, and finally one is the RSVG protein. And they found that the purified F protein was moderately immunogenic, means it partially worked, but it didn't do that great a job. they found that the co-purified FG and M protein for only the RSA type worked very well for adults. It had an efficiency of around 76 to 93%, but it would require annual vaccines. And then with the RSVG protein, again, it gave moderate immunogenic properties to adults, but it had some severe side effects, so they stopped that. So your best choice is the co-purified FG and M proteins, but it only works for type A, and it has to be done annually. They have also done some research on these recombinant vaccines, such as chimeric bovine human PIV-3 strain, and this is a bioengineered strain of vaccine, and it was given intranasally, basically just like the flu vaccine. It's like an intranasal spray, and it actually works on both types, type A and type B. They started doing clinical trials. They are on phase 1 and phase 2, and they're working into the phase 3 results. And the results of this are very promising. So, they're working on it, but most of this stuff is going to require annual vaccines, which we have not just quite got there yet. It seems that the elderly population who are predisposed to RSV infections would benefit from a vaccine program. The data is extremely limited, and because a lot of these vaccines don't work on type A and type B and kind of expensive to produce, and we require annual vaccines, annual giving of the vaccine, there's some drive for this at this point. You would think with all the influenza vaccines that have been on the market that we would be doing something with RSV, but they're working at it. They actually shown they have another type of vaccine called a purified subunit F protein, and this induced moderate increases in neutralizing antibodies in healthy elderly adults. So they got some vaccines on the market. They give a partial immunity. They work a lot for the type A and type B, but they are all going to require an annual dose. So I think at this point where we got a good handle on influenza, that we should consider maybe creating a good vaccine and getting an annual shot for RSV. It'll just increase our longevity. It'll actually decrease the economic burden of illness in the community, especially the elderly community. So it's promising, but I guess it's a very tough bug to manage. It's not that easy, and because there's 2 variants of type A, type B, it gives these researchers a lot of problems. But I want to thank you for joining me. So some final thoughts. Obviously, we need some more research. We need to develop a vaccine that works. In the meantime, we have to identify those who have RSV infections earlier than later. An ounce of prevention is worth a pound of cure. And no matter what we do, we have to improve our infection control practices. Good hand washing, cohorting patients is the basics of all this. And these are the things you got to do. And thank you very much again for joining my presentation. And if you have any questions, I'm here for you. Here is a short list of references. They're all pretty good. There's new stuff coming out every day. So even when I was researching this topic, there were some clinical trials going on that I did not show you, but there's some new stuff out there, but I think I covered it pretty well, and thank you very much, and hope to see you soon. Any questions, my friends? I'm here.